Imagine you're on your clinical rotation, starting a new shift on the med-surg floor. You get a handover about Miss Eleanor Vance, a 42-year-old high school teacher in room 304. The report says she's here for intractable pelvic pain and urinary frequency. As you walk in, you see her sitting on the edge of her bed, her face etched with exhaustion and frustration. She tells you this is her 5th visit to a healthcare facility in 6 months. She describes a constant, nagging, pressure-like pain deep in her pelvis, a feeling she compares to a bladder that's always full and irritated. The feeling is relentless, a background noise to her entire life. She continues, her voice trembling slightly. It feels like I have the worst urinary tract infection of my life, but every single time the tests come back negative. No bacteria, nothing. I've been on so many courses of antibiotics and they do absolutely nothing to help. I have to go to the bathroom, I swear, 30, maybe 40 times a day, and when I go, it's just a tiny amount. The urgency is so intense that I can't even get through a single class period without running out. I've stopped drinking coffee. I've avoided my favorite spicy foods. I feel like my bladder is controlling my entire life, and I'm at my wit's end. This scenario is classic for a condition that often masquerades as a chronic UTI, but is something else entirely. As her nurse, you note her vital signs are stable and she has no fever. Her lab work, including urinalysis and culture, confirms what she said, no signs of infection. This is a pivotal moment in her care journey. You're not just looking at a set of symptoms, you're looking at a person whose quality of life has been decimated by an invisible illness. Understanding this condition is your first step toward providing the compassionate, effective care that patients like Miss Vance desperately need. Your role here goes far beyond just administering medications. It involves education, emotional support, and helping her navigate a complex diagnosis. The puzzle pieces are scattered: persistent pain, extreme urgency and frequency, and negative urine cultures. Putting them together requires a different kind of thinking, moving away from infection and toward inflammation. This is where your knowledge of interstitial cystitis or painful bladder syndrome becomes crucial. You will be her advocate, her educator, and a key part of the team that helps her reclaim control from this debilitating condition. Your journey to understanding IC starts now. Before we dive deep into what goes wrong in interstitial cystitis, let's do a quick refresher on how the urinary system is supposed to work. Think of it as the body's ultimate plumbing and filtration system. It's a team of 4 key players working in perfect harmony to remove waste products from your blood and expel them from your body as urine. It's an elegant design, really, and when it's functioning properly, you barely even notice it's there. The main goal is to maintain homeostasis by regulating water balance, electrolytes, and blood pH, all while getting rid of metabolic waste. First up, we have the kidneys. You have 2 of these amazing bean-shaped organs, each about the size of your fist, located on either side of your spine, just below your ribcage. The kidneys are the powerhouse of the system. They are constantly filtering your blood, around half a cup every minute, removing waste products like urea and creatinine, and balancing fluids and electrolytes. They are the sophisticated purification plants of your body. Once the kidneys have produced urine, it doesn't just sit there. It needs a way to get to the next station for storage. This is where our next players come in. Flowing from each kidney is a long, thin tube called a ureter. These 2 muscular tubes act as conduits, actively propelling urine downward from the kidneys to the bladder using waves of muscle contractions called peristalsis. They are the delivery pipes, ensuring the waste-laden fluid makes its way to the storage tank without any backflow. The ureters connect to the bladder, our central storage unit. The bladder is a hollow, muscular, and incredibly stretchable organ located in your pelvis. Its main job is to collect and store urine, expanding like a balloon as it fills up. When the bladder fills to a certain point, typically around 200 to 400 milliliters, stretch receptors in its walls send signals to your brain, letting you know it's time to find a restroom. This is that familiar sensation of needing to urinate. Finally, when you decide it's time to go, your brain sends a signal back down. The bladder muscle contracts and a sphincter at its base relaxes, allowing urine to flow out of the body through the final component, the urethra. This is the exit tube, and it's much shorter in women than in men, which is a key anatomical difference. This whole process is a beautifully coordinated dance between muscles and nerves. unmasking the mystery. So now that we know how a healthy bladder works, let's talk about what happens when things go wrong, as in the case of interstitial cystitis, which is also called painful bladder syndrome. At its core, IC or PBS is a chronic condition characterized by bladder pressure, bladder pain, and sometimes pelvic pain, ranging from mild discomfort to severe, debilitating pain. The key thing to understand, and this is a huge point for your exams and for patient education, is that IC is not an infection. It's a condition of chronic inflammation and irritation of the bladder wall, but without a known cause. This is precisely why it's often called a diagnosis of exclusion. This means that doctors have to rule out all other possible conditions that could be causing the symptoms before they can land on a diagnosis of IC. They will test for urinary tract infections, bladder cancer, kidney stones, endometriosis, and sexually transmitted infections, among other things. When all of those tests come back negative, yet the patient's symptoms of pain, urgency, and frequency persist for at least 6 weeks, IC or PBS becomes the likely culprit. This diagnostic journey is often long and frustrating for patients who may feel like no one believes their pain is real. So, what are we really talking about? Imagine the inside of your bladder is supposed to have a smooth, protective lining like Teflon. In IC, it's thought that this lining becomes damaged or leaky, more like sandpaper. This allows substances in the urine that are normally harmless, like potassium and other acids, to seep through and irritate the sensitive bladder wall and nerve endings beneath it. This constant irritation leads to chronic inflammation, which in turn causes the hallmark symptoms of pain and the relentless need to urinate. It's a vicious cycle of irritation and inflammation. It's also important to know that IC or PBS exists on a spectrum. For some people, it's a mild but persistent annoyance. For others, it's a life-altering condition that impacts work, relationships, and mental health. There is no single cure for IC, so management focuses on a multi-pronged approach to control symptoms and improve quality of life. As a nurse, you are central to helping patients find the combination of treatments and lifestyle changes that work for them. It requires patience, empathy, and a deep understanding of the condition's mysterious and often frustrating nature. While the exact cause of interstitial cystitis remains one of medicine's frustrating mysteries, we have identified several risk factors and common triggers that can initiate a flare-up or worsen existing symptoms. Understanding these is absolutely critical for patient education. Knowing who is at a higher risk can help with earlier suspicion and diagnosis. Statistically, IC or PBS is much more common in women than in men, with some estimates suggesting that women are affected up to 10 times more often. The condition typically develops in early to middle adulthood, most often in a person's 30s or 40s, just like our patient, Miss Vance. There also appears to be a link with other chronic pain and inflammatory conditions. It's not uncommon for a person with IC to also have diagnoses like irritable bowel syndrome, fibromyalgia, chronic fatigue syndrome, or certain autoimmune diseases like lupus or Sjogren's syndrome. This suggests there might be an underlying issue with the body's inflammatory or pain signaling processes, a kind of systemic hypersensitivity. A personal or family history of bladder problems or pelvic pain can also increase someone's risk, hinting at a possible genetic predisposition, though this link is still being researched. Beyond the risk factors, identifying individual triggers is a cornerstone of managing IC. These are specific things that can cause a person's symptoms to spike, known as a flare. For many, dietary triggers are the most significant culprits. Think of the 4 C's: caffeine, carbonated drinks, citrus fruits, and foods high in vitamin C or ascorbic acid. Other common offenders include tomatoes, spicy foods, artificial sweeteners, especially aspartame, and alcohol. The best way for a patient to figure out their specific triggers is often through an elimination diet, where they remove all potential irritants and then slowly reintroduce them one by one. It's not just about what you eat or drink, though. Lifestyle factors play a huge role as well. Stress is a massive trigger for many people with IC. The brain-bladder connection is very strong, and emotional or psychological stress can directly translate into physical symptoms in the bladder. Other triggers can be physical. For example, wearing tight clothing like skinny jeans can put pressure on the abdomen and pelvis, worsening discomfort. Certain types of exercise, especially high-impact activities like running, can be problematic for some. Even sexual intercourse can sometimes trigger a painful flare-up. Helping patients become detectives of their own bodies is a key nursing role. When it comes to the NCLEX and real-world practice, you need to know the classic presentation of interstitial cystitis like the back of your hand. The symptoms can be boiled down to a hallmark triad: pelvic pain, urinary urgency, and urinary frequency. While other symptoms can occur, these three are the core pillars of the condition. They are what drive patients to seek help and what cause the most significant disruption to their daily lives. Remembering this triad is key to differentiating IC from other urinary issues. Let's break each one down. First, let's talk about pain. This is not just a mild ache. It can be a severe chronic pain that is centered in the pelvic region. Patients often describe it as a feeling of pressure, tenderness, or intense aching above the pubic bone, in the lower back, or in the perineal area. For women, the pain can be in the vulva or vagina, and for men, it can be in the scrotum, testicles, or penis. A classic characteristic of IC pain is that it often gets worse as the bladder fills with urine and is temporarily relieved, even if just slightly, by emptying the bladder. This fill-and-void pain cycle is a huge clue. Next up is urinary urgency. This is not the normal feeling of "I should probably go to the bathroom soon." This is a sudden, compelling, and often overwhelming need to urinate immediately. Patients describe it as a sensation they simply cannot ignore, causing them to drop everything and run to the bathroom. This urgency contributes significantly to the anxiety associated with the condition, as people live in constant fear of not being able to find a restroom in time. This is why many people with IC know the location of every public toilet in their town and may avoid going to places where facilities are not readily available. Finally, we have urinary frequency. Because of the constant irritation and the faulty signals being sent to the brain, people with IC feel the need to urinate far more often than normal. A person without bladder issues might urinate 6 to 8 times in a 24-hour period. Someone with severe IC might urinate up to 40, 50, or even 60 times a day, including multiple times throughout the night. This is called nocturia. The cruel irony is that despite the intense urgency and frequency, they often only pass a very small amount of urine each time. This constant disruption, especially at night, leads to chronic fatigue and exhaustion. To truly understand interstitial cystitis, we need to zoom in and look at the pathophysiology. What's actually going on at a microscopic level inside the bladder wall. Normally, the innermost layer of the bladder, called the urothelium, is protected by a special coating. This coating is made of compounds called glycosaminoglycans, or GAGs for short. Think of the GAG layer as a waterproof protective shield. Its job is to prevent toxic substances and irritating solutes, like potassium ions, that are concentrated in the urine from coming into contact with the delicate tissues of the bladder wall underneath. In many theories about IC, the central problem is a defect in this GAG layer. It's thought to be thin, damaged, or leaky. When this protective shield is compromised, those irritating substances in the urine can seep through the urothelium and penetrate deeper into the bladder wall. This is like having a cut on your skin and then pouring lemon juice on it. It's going to sting and become inflamed. This chemical irritation is believed to be the initial event that kicks off a cascade of other problems within the bladder tissue. Once those urine solutes get through the GAG layer, they activate 2 key players in the deeper layers of the bladder wall: mast cells and nerve endings. Mast cells are a type of immune cell famous for their role in allergic reactions. When activated, they release a flood of inflammatory chemicals, including histamine, which causes pain, inflammation, and further damage to the surrounding tissue. This is why some antihistamine medications can be helpful in treating IC symptoms. The irritation also directly affects the C fibers, which are specific nerve endings that transmit pain signals to the brain. This process sets up a vicious, self-perpetuating cycle of neurogenic inflammation. The irritated nerves send pain signals up to the brain. In response, the brain sends signals back down that can cause even more mast cell activation and inflammation. Over time, this chronic inflammation can lead to physical changes in the bladder wall, such as tiny pinpoint hemorrhages known as glomerulations, or larger, more inflamed patches called Hunner's ulcers, though these are only seen in a small minority of patients. This entire cascade explains the chronic pain, the hypersensitivity, and the constant feeling of needing to go. One of the most common challenges in diagnosing interstitial cystitis is distinguishing it from a classic urinary tract infection, or UTI. The initial symptoms can look incredibly similar: painful urination or dysuria, urgency, and frequency. Many patients with undiagnosed IC are mistakenly treated with multiple, ineffective rounds of antibiotics for what is assumed to be a recurrent UTI. As a nurse, knowing the key differences is crucial for patient advocacy and education. You will be the one explaining to the patient why their UTI isn't responding to antibiotics and what the next steps might be. The single most important differentiating factor is the result of a urinalysis, and more specifically, a urine culture. In a classic UTI, the urinalysis will typically show positive leukocyte esterase and nitrites, and the urine culture will grow bacteria, most commonly E. coli, confirming an infection. In interstitial cystitis, the urine is sterile. The urinalysis and urine culture will consistently come back negative for bacteria, while some white blood cells, or puria, or red blood cells, meaning hematuria, might be present due to inflammation. There will be no bacterial growth. This is the definitive laboratory distinction. Let's look at the nature of the symptoms. While both can cause pain, the character of the pain can differ. UTI pain is often described as a sharp, burning sensation during urination. IC pain is more often a chronic pelvic pressure or ache that gets worse as the bladder fills and is relieved by urination. Furthermore, a UTI is typically an acute event. It starts, it gets treated with antibiotics, and it resolves within a week or two. IC, on the other hand, is a chronic condition. The symptoms are persistent, lasting for months or years, and they often wax and wane in intensity, with periods of flare-ups and remission. Finally, consider the broader clinical picture. A severe UTI can sometimes be accompanied by systemic signs of infection, such as fever, chills, and flank pain, if it has ascended to the kidneys. These systemic signs are generally absent in IC or PBS, which is a localized inflammatory condition of the bladder. Helping patients and even other healthcare providers understand this distinction is vital. It prevents the overuse of unnecessary antibiotics, which contributes to antibiotic resistance, and it opens the door to appropriate targeted therapies that can actually help manage the chronic inflammation of IC. Managing interstitial cystitis is not about a single magic bullet. It's about a comprehensive, multi-layered approach tailored to the individual patient. As a nurse, you are instrumental in teaching and supporting patients through this process. A great way to remember the key interventions for the NCLEX and for your practice is the ABCDE mnemonic. This covers the essential domains of care: avoiding triggers, bladder retraining, comfort measures, drug therapy, and education and emotional support. Let's break down each component of this essential nursing playbook. A is for avoiding triggers. This is step one and often the most impactful intervention. This involves dietary modification. You'll teach patients about the IC diet, encouraging them to start by eliminating common irritants like coffee, tea, soda, alcohol, citrus, tomatoes, and spicy foods. An elimination diet followed by careful reintroduction is the gold standard for identifying personal trigger foods. You can also suggest an over-the-counter supplement like calcium glycerophosphate or pre-leaf, which can help neutralize acid in foods, allowing some patients to tolerate them better. Lifestyle modifications like wearing loose-fitting clothing and avoiding high-impact exercise are also part of this step. B is for bladder retraining. This behavioral therapy aims to break the cycle of frequency and urgency. The patient starts by keeping a bladder diary to track voiding patterns. Then, under your guidance, they begin to resist the first urge to void and hold their urine for a set period, say an extra 5 or 10 minutes. The goal is to gradually increase the time between voids, stretching the bladder and training the brain to be less sensitive to bladder signals. This requires a lot of patience and persistence, but can significantly improve frequency and bladder capacity over time. It's about regaining control over the bladder, rather than letting the bladder control them. C is for comfort measures. These interventions are focused on direct pain relief, especially during a flare-up. Applying a cold pack or a warm heating pad to the perineum or lower abdomen can provide significant comfort. Stress reduction techniques are also a huge part of this. You can teach patients about deep breathing exercises, mindfulness, meditation, or gentle yoga, as stress is a major trigger for IC flares. A warm bath, without irritating soaps or bubble baths, can also help relax pelvic floor muscles and soothe pain. Physical therapy with a specialist in pelvic floor dysfunction can also be incredibly helpful to release muscle tension. D is for drug therapy. When lifestyle changes aren't enough, medications are added. The only oral drug specifically FDA approved for IC is pentosan polysulfate sodium, also known as L-Myron. It's thought to help restore the damaged gag layer of the bladder, but it can take months to work and has potential side effects, including rare but serious eye issues. Other oral meds used off-label include tricyclic antidepressants like amitriptyline to block pain and reduce urgency, antihistamines like hydroxyzine to calm mast cells, and bladder antispasmodics. For severe flares, bladder instillations or cocktails containing substances like dimethyl sulfoxide, heparin, or lidocaine can be instilled directly into the bladder via a catheter to provide direct relief. All right, let's get you ready for the NCLEX. When you see a question about a female patient in her 30s or 40s with chronic pelvic pain and urinary frequency, but her urine cultures are repeatedly negative, your brain should immediately scream interstitial cystitis. The keywords are chronic, pain with bladder filling, relief with emptying, and negative cultures. Examiners love to test your ability to differentiate IC from a UTI. Remember the golden rule. If there are no bacteria, it's not an infection. Don't pick antibiotics as the answer. Let's lock in the key concepts with a mnemonic. For the hallmark symptoms of IC, remember the PUFF test, because the bladder feels puffed up and irritated. P stands for pain, pelvic pain that worsens with filling. U is for urgency, a sudden, overwhelming need to void. F is for frequency, needing to void very often, day and night, that's nocturia. And the last F is for flare-ups, symptoms that come and go, often tied to triggers. This simple mnemonic can help you quickly recall the classic presentation during a high-pressure exam situation. For patient education on diet, think say no to the 4 C's caffeine, like coffee, tea, and some sodas, carbonated drinks, citrus fruits and juices, and vitamin C in high doses, as ascorbic acid. This is a super common trigger category, and teaching patients to avoid these is a priority nursing intervention. For NCLEX questions about management, always prioritize the least invasive interventions first. This means you should look for answers related to patient education, dietary changes, like avoiding the 4 C's, and stress management before you jump to medications or more invasive procedures like bladder installations. Now, let's test your knowledge. Time for a quick quiz. 1. A nurse is caring for a client diagnosed with interstitial cystitis. Which statement by the client indicates an understanding of the condition? A. I will need to take antibiotics for the rest of my life to manage this infection. B. My bladder is inflamed, but it's not infected, so I need to identify my triggers. C. This condition is acute and should resolve completely within a few weeks. D. I should drink a lot of cranberry juice to help my bladder heal. 2. When developing a plan of care for a client with painful bladder syndrome, which of the following is the priority nursing intervention? A. Administering a course of broad-spectrum antibiotics. B. Preparing the client for immediate bladder surgery. C. Teaching the client about bladder retraining and keeping a voiding diary. D. Instructing the client to increase fluid intake with carbonated beverages. Quiz answers. 1 is B, 2 is C. How did you do? Remember these key points, use the mnemonics, and you'll be well equipped to handle any IC or PBS questions that come your way on the NCLEX, and more importantly, to provide excellent care to your future patients. You've got this.